Hello, everyone, and thank you for joining. My name is Julia Mulliken, and I'm the Physician and Community Liaison with Buffalo Rehab Group. Tonight, we're going to be talking all things shoulder. And to start us off, I am joined with Dr. Matt Binkley from UBMD Orthopaedics and Sports Medicine. Thank you for joining us, Matt.
Yeah, absolutely. Thank you for having us.
So to start off, you're going to kind of understand, what the shoulder is. But before we do that, can you kind of tell the audience a little bit about yourself and how you ended up here and working at UBMD?
That's certainly $1 million question. But so I came from Southern Ohio. I had 3 younger brothers, and I came to Buffalo for residency and training. Lo and behold, I ended up marrying a Buffalonian, which, as we all know, means that I was bound to return. So I went to Baltimore and did a shoulder fellowship for a year. I actually worked in Ohio for an additional year at a VA, helping out the veterans doing shoulder issues, and then moved back to here, where we're here to stay.
Awesome. And you're liking it so far?
Well, it's been 3 years. I don't know if I'll ever still get used to all the winters, and
yes, I agree.
but luckily it's almost done. So.
And now you're converted to a Bills fan?
Halfway.
Yeah.
So my Bengals looked pretty good last year,
Yeah.
deservedly or undeservedly. But
Yeah.
either way, 2 of the best 4 teams I'm a fan of, so I'm okay with that.
There you go. It's a good season for you. So, all right. So kind of to start, I want to talk about what types of injuries people sustain within the shoulder and kind of what treatment options are available. So I think a great place to start in a lot of really well-known area is the rotator cuff. So can you kind of explain what the rotator cuff is, how it's kind of utilized within the body?
Yeah, so rotator cuff injuries are very, very common, and the role of the rotator cuff is to stabilize the shoulder. So the shoulder itself is a ball and socket joint, and what the rotator cuff does is it stabilizes the ball against the socket. A lot of people like to think of the shoulder as a golf ball on a tee, and what the rotator cuff is, and when you think about it from that standpoint, is the stabilizing force that will keep the ball, despite teetering, on the tee itself. Rotator cuff injuries come in multiple varieties. There's partial thickness tears, which I always tell people are like gray hair. Unfortunately, we all end up accumulating some of them, even myself. And then they also come in the variety of full thickness tears, where the tendon itself is no longer on the bone. And those are the ones that end up providing the most problems for patients and needing the most treatment.
Mm-hmm. So you've kind of brushed on it. So can we talk a little bit further about what types of injuries occur here in this area?
As far as the rotator cuff or shoulder in general?
Let's hit both.
Okay. So rotator cuff injuries, they come in 2 different varieties. There's either degenerative tears, as in, I don't know when my shoulder became a problem, but it's gradually has become a problem over the last months, years, whatever, or acute tears. And in the winter, I'll use the example of I was walking out to get the garbage or get the mail. Mm-hmm. Next thing you know, you end up on the ground and you have a shoulder issue, a rotator cuff tear. Other things that can happen through your shoulder, there's shoulder instability, shoulder dislocations, which if you're a Bills fan, occasionally you will see. There's labral tears that can occur with that. Frozen shoulder is not necessarily an injury, but something that we do commonly see, very commonly in diabetics and middle-aged women. A lot of times we'll get this as well, where the shoulder itself kind of ceases to move and becomes very painful. And then, of course, at this time of year especially, we do see the fractures of the shoulder, which do occur very commonly.
And why specifically this time of year?
Ice and snow.
Okay.
So again, unfortunately, we all have to be outside for some period of time, even in the winter.
Yeah.
So it's not uncommon to accidentally fall and slip. And as everyone always says, it was something stupid. They usually like to say I was taking a step and just landed, awkwardly or weird. So.
Ugh, yeah. What do you typically see or maybe hear from a patient that kind of struggles with pain in this area from them?
One of the biggest things that is a big telltale sign for me is sleeping pain. So patients that have significant rotator cuff pathology or any shoulder-related issue, when it affects their sleep is usually when they're very interested in meeting myself or another orthopedic surgeon. Mm-hmm. Patients will tolerate a lot, but they won't tolerate when their sleep is being messed up because of pain. A lot of times patients will talk about difficulty overhead activities, so I can't get to the top of the drawer mm-hmm. or reaching far from their body. Okay. Those are situations in which your rotator cuff needs to be stable or a stabilizing force for your shoulder. Mm-hmm. And when patients begin to struggle with that is when they begin to look for help.
And talk about another common thing that I'm sure maybe you see is kind of an arthritis in that area too. So what's happening with that?
So arthritis commonly occurs after dislocations, after many, many years, after other injuries, or it can happen just because of genetics, time, and usage. So if you think of shoulder arthritis as the road, and so the nice smooth paved road that we sometimes see in the summer, or hopefully see in the summer, versus the road you see now where there's potholes, there's cracks everywhere. That's what arthritis is for your shoulder. So instead of this smooth gliding surface, you're now getting cracks, potholes, and so with certain motions you're getting clicks, pops, and often pain as well.
Okay. So let's say someone comes to you with these types of injuries. What are really their treatment options that they have available to them?
Yeah, so with any orthopedic issue, you have non-operative and operative treatment. Non-operative treatment usually starts with activity modification. A lot of times patients, before they've met me, have done a lot of these things. So that means either change what you're doing or change how you do it. Sometimes that's easier said than done, of course, which leads us to number 2, which would be anti-inflammatories or Tylenol. Anti-inflammatories come in a lot of different varieties. There's Motrin, there's Celebrex, there's meloxicam. They're all the same, but they're all potentially different and work better for others. Then the third option would be injections. Injections can come in the course of corticosteroids, which are very common, versus other injections, which are somewhat experimental for the shoulder. Physical therapy is always a mainstay of treatment. And then lastly, surgery, of course, which most patients try to avoid, and sometimes we can avoid it, but not always.
And if someone, let's say, you're trying to work through all of those symptoms and then your resort is surgery, talk to us kind of what comes next if you have to have surgery.
Yeah, so for patients that have surgery, obviously there's differences between this, but generally there's 6 weeks of immobilization where you're in a sling. I always tell patients that following surgery, you're able to type, you can write, you can use your arm, but you cannot move your shoulder usually for about 6 weeks or so. Therapy usually will start around the 6-week mark and last anywhere between 6 weeks to 3 to 4 months, depending on the procedure in person. Any shoulder surgery takes approximately a year before it kind of feels like 100%. You're not thinking about your shoulder, you're not worried about your shoulder. And generally, for most shoulder issues, at 3 months, you can begin doing any and all of your normal activities.
So limitations, kind of keeping that, and then the result is a fully functioning shoulder. Is that the hope of it?
That's certainly the goal. Obviously, again, that comes with the caveat of what did you start with, and what medical conditions, how good are you with rehab, how good are you at following post-operative restrictions, and that kind of stuff as well. So the goal certainly is 100%. Where you end up kind of depends on other factors too, though.
And I wanted to circle back to something that you talked about before. You mentioned frozen shoulder and how it really specifically only affects, or a majority of women too. Can you kind of elaborate on maybe why that is too?
Well, that's kind of hard to say. So when we're looking at frozen shoulder, it does seem to hit certain subgroups a little bit more specifically. So patients that have thyroid issues, patients that have diabetes, and then it does seem to be women. So a lot of times people will fit into one of those categories, but obviously not always. So the real question is we don't know. Okay. But what is important is that 20% of patients will get it on the contralateral side. And again, the good thing about this, if there is something good, is that generally physical therapy and injection or two will kind of take it through its course.
And for us non-clinicians out there, what does contralateral mean for those watching?
So the opposite side. So it's not bad enough to get tortured on one side. Sometimes you end up getting tortured on the other.
Very nice. We love that, don't we?
Yeah, absolutely.
And then talk about, I think we kind of brushed over this one, but what do people mean when they say they have like an impingement of their shoulder too?
Yeah, so impingement can mean a lot of different things. Often I will hear patients actually who have frozen shoulder or stiffness say that they have impingement, which is not exactly the same. So impingement generally means that the rotator cuff goes into this small space below you, this bone on top of your shoulder, and actually will get pinched with certain motions. Okay. So generally that can be responsive to physical therapy, that can be responsive to injections, but occasionally also does need to be treated with surgery.
And what type of motions would they typically see that with?
Again, it's usually your overhead motions.
Okay.
So a lot of times it's a twisting motion, overhead type stuff. But generally you still get the night pain. You still get difficulty with certain motions, namely overhead.
Great. How does somebody know if they're ready for surgery? So what would you be looking for them?
Yeah, so that's going to be a personal decision. But the big things to look for are after you've trialed non-operative treatment, you still can't sleep. It's affecting your activities of daily living and ability to perform those. It's affecting your quality of life to a significant degree. And so I think those are the big 3 things I look for, that if you can check all those boxes, then it's probably time to have something done.
Great. And then obviously looking for somebody that specializes in the shoulder too? Is that what you would want for them?
That's what I would want as the patient. So, yeah, that's what I would recommend, certainly.
Great. Talk a little bit more about like the potential injections that maybe they have options to. Is there just one, or is there several options?
This is kind of a hot topic in orthopedics, and so corticosteroids have been kind of tried and true. So when patients normally come in and say, I've received an injection or I want an injection, it's normally corticosteroids, which are good generally at getting rid of pain, although somewhat unpredictable. Other types of injection, there's Synvisc or the gel type shots. They've been trialed in many places in the shoulder. They're generally not that effective, at least based on the research there. There's PRP, which is very popular and often patients ask for, which has some indications in the shoulder, but not very many. And then lastly would be stem cell research, which from the shoulder standpoint, we're kind of far away from implementing that, but certainly in the future it would be something that would be an option.
Great. And then my favorite question to ask is, what research are you excited about in the future for shoulder patients too?
Well, there's a lot of new stuff coming out. So I think a lot of the biologics will be certainly the future of the rotator cuff type stuff for the shoulder, and hopefully we'll be able to treat a lot more pain type symptoms through the shoulder with that. I think our shoulder replacements are getting better and better. We have better implants. I think being able to reliably give patients good range of motion, regardless of pathology through the shoulder, is certainly where there's a lot of research being focused, and something hopefully we as a community will be able to deliver more predictably.
Awesome. We have one question from the audience right now. So sometimes I have difficulty knowing how far to push my shoulders when exercising. How do I know when I should back off of a plank or a push-up?
That's a great question, and unfortunately I don't know the exact diagnosis there. Generally what I'll say is with any stretching exercise or activity in general, it should get to the point of discomfort, but it should not be painful. All right, once you get to a point where it's painful, that's when you need to back it down a step. But as far as stretching goes, there should be some level of discomfort, and for most people I'll tell them to get to that point and then hold it. A big thing with stretching, and which I always tell people, is not enough to get to a point to where you feel like you're getting a stretch, but it's to get to that point and hold it for 10, 20, 30 seconds so you really get the full kind of benefit from that.
Awesome. Well, thank you so much. You whipped through all of my questions, cruising through it. So if somebody's interested in home and they're realizing that maybe this is something they need to look at, you know, like you said, it's interrupting their sleep too, how can they get in touch with you?
Yeah, they can call my office, 740-8140, and I'm always happy to see anyone.
Awesome. Well, thank you guys so much, and we'll be right back. We're going to go to a quick break, and then we'll be back with physical therapist Matt Profeta to kind of talk about how we strengthen that shoulder, so then hopefully you'll just be doing some preventative work with them, right?
Yeah, absolutely.
All right. Thanks again.
No problem.
This is where Leah learned to dribble, where James first picked up a brush, where Bella made meal kits for neighbors in need. This school year, many YMCAs are transforming some of their spaces for virtual learning, dedicating staff and even providing meals. So now, this is also where they will master long division, study photosynthesis, and learn when they need support, the Y is there for them. The Y, forever learning for a better us.
Pain was really bad, and it was very crippling. A lot of pain. Yeah, there were times when you thought, this is it. The main thing that it really prevented me doing was from being with the grandchildren. But the exercises that he taught me, little by little, I saw progress. I'm back to my normal life. Besides getting you better, they teach you how to live a life that will prevent you from going backwards again. They all care about the patients. That's where you're going to find your hope, and that's where you're going to feel better. Okay.
So hopefully you had a drink of water, got some stretching in, because we're ready to get moving, right, Matt?
Yep, I'm ready.
So we just talked to Dr. Binkley before, and now I want to introduce Matt Profeta. He is a physical therapist. I guess you could introduce yourself to everybody.
You're doing a good job, but
I was going to keep rattling off all your different things, but I'll let you do it.
Thank you. Hi guys, I'm Matt Profeta. I'm a physical therapist here with Buffalo Rehab Group. I originally opened up our Kenmore location in 2017, and we actually just opened up our Hurdle Parkside location that was 3 weeks ago. So
Yes.
we're just getting rolling. So I went to DuVille College. I graduated in 2014, and I started with Buffalo Rehab Group in 2016. So
Very nice. And you're still liking it.
so far,
Yeah.
jury's still out. I'm not really sure yet. So.
Awesome. Well, so Dr. Binkley kind of walked through, what the shoulder is, talking about the rotator cuff and some of the different injuries and the options for people when they injure that. But now we really want to talk about strengthening those shoulders, so hopefully we either prevent those injuries or obviously if they have one of those, really healing them again. So can you kind of talk about that? Most people think maybe the shoulder is the most important, but it's maybe not the shoulder
Sure.
that is important for the movement of it.
Yeah, so a lot of times patients will come in and, Dr. Binkley did a great job explaining, a little bit about anatomy and the rotator cuff. And, that's one of the most popular questions we get with patients as they come into the office. They're always curious, like, they have shoulder pain and they say, is this my rotator cuff? And, they're so focused on the shoulder itself, that ball and socket joint. But a lot of times what we see here is that's really more so just like the painful tissue, right? So that's where a lot of the pain is. But that's not really the root of the issue. So there's a lot of times we'll talk to patients about there's painful tissue and there's dysfunctional tissue. So painful tissue is usually pretty easy to find. Like we tell patients, like, where does it hurt?
Yeah.
And they'll usually point to their shoulder. However, what we see with most patients is the dysfunctional tissue is really more so around the shoulder blade. So we see that commonly around the shoulder blade and also the mid-back. So those are the areas that don't move properly, and they will push increased stress to the shoulder and cause a lot of that wear and tear on those structures like the rotator cuff, causing more like that tendonitis, impingement, and all those other diagnoses that we see commonly in the clinics.
Awesome. So throwing off this, you kind of talked about it, but we'll elaborate a little bit more about what throws off this rhythm.
Sure,
right?
Sure. So when we look at how the shoulder moves with patients, so when we're typically reaching up overhead, if you boil it down, the shoulder is basically made up of two different bones. We have our upper arm bone, our humerus, and we also have our shoulder blade. So they do this little bit of like a song and dance called the scapulohumeral rhythm. So when someone reaches up overhead, these two structures, the shoulder blade and the upper arm bone, the humerus, they have to work together in order to complete that task of reaching up overhead. So in normal anatomy or ideal anatomy, the scapulohumeral rhythm functions in a 2-to-1 ratio. And what that means is every 2 degrees that the humerus moves, the scapula will move 1 degree. So in that 2-to-1 ratio, that's like the little song and dance as they're moving together. Now, in abnormal rhythm, with that scapulohumeral rhythm, it's usually in like a 9-to-1 ratio, which means that the humerus or the upper arm bone is moving 9 degrees, where the shoulder blade is only moving 1 degree. So there's a big discrepancy between those two, and that will kind of add more stress to the ball and socket joint and increase that wear and tear. And that's where we see a lot of that breakdown start to happen. Is it starts at the shoulder blade and then it ends up affecting the ball and socket joint itself.
And what is throwing off this rhythm?
So there's a lot of things that throw off that rhythm. One of the biggest things we see with a lot of patients is, unfortunately, in our current society, we are all on computers, like we probably are right now, and we're sitting there, and our shoulders are rounded, unfortunately. And what that really does is the shoulder blade starts to tip forward, and it changes the angle again of that scapulohumeral rhythm, and it starts to push more stress again to that ball and socket joint, which can affect more of those structures and put more stress on them.
So I know all of you watching at home just
immediately
immediately right-size your posture to sit up a
So
little bit better.
You're welcome.
So in 10 minutes when you start slouching again, we'll remind you again about it.
Yep, absolutely. There's other things that can play into, that rhythm or what's throwing off that rhythm. So one of the biggest things, like we just talked about posture, one of the other things that we think about posture is, does someone have the prerequisite strength in order to maintain that posture? So the strength around that ball and socket joint, the strength around those scapular muscles, or around the shoulder blade or the scapula, can someone, number one, get into that position, but can they maintain that position? Think about most patients are, if they have a desk job, they're sitting at that desk for, extended periods of time, 6-8 hours a day, and then you project that across the week, that's a lot of hours in that seated position. So A lot of times we'll see for the patients, yes, they're able to sit up straight for a little bit, but they kind of just, melt down after, 5-10 minutes, and they're right back to that bad positioning. And if you think about that over the course of the week, it's like that death by 1,000 cuts presentation. Maybe if you just sit there for a couple minutes, it's not a big deal, but if you do that hours upon hours, it starts to accumulate and it puts a lot of stress on those shoulders. Another thing that we see along with posture and like the weakness in the upper back or around the shoulder blade is that stiffness. So that also comes with being stuck in that same position. We see a lot of stiffness or immobility in that mid back area, so like right between the shoulder blades. I couldn't tell you how many patients come in like, I feel like I got like a stiffness right in between my shoulder blades, like that spot I can't really reach or can't really mobilize. So that usually happens from that rounding of that shoulder. Our mid-back gets kind of stuck in that position. It gets used to being in that position. So to move out of that position, it's very stiff and immobile. And that's really one of the first areas that we start to target for patients that have shoulder pain, is starting there and getting that area moving first, along with getting the area stronger. And then that also leads to a better posture.
And so when this rhythm is off, and we know it's been caused by a few of these factors and probably more smaller things, what injuries occur from these?
So just like we talked about before, when one area stops moving, it's going to push force or push stress to another area. So just like we talked about before, like if that shoulder blade area or if that mid-back area isn't moving well, it's going to put more stress on the rotator cuff. It's going to put more stress on that ball and socket joint. So it can lead to any type of rotator cuff injuries. It can lead to impingement. It can lead to tendinitis. Long standing, it can also lead to osteoarthritis in the shoulder. So if you have patients that are commonly complaining about reaching up overhead and snap, crackle, pop, or a lot of grinding in the shoulder, that may be indicative of some osteoarthritis in that shoulder as well. Again, because of the wear and tear from all those things that weren't happening before.
So then really just trying to focus on sitting up.
Yeah, it kind of starts there, changing that behavior of, first things first is like awareness, especially for patients that have desk jobs, being aware of it. I've had patients, I'll tell them to set a timer every, 20, 40, every 60 minutes, something like that, just to give them that reminder, that cue, like, okay, let me check my posture. Where am I at this point? Am I crouched or am I slouched over, my keyboard? Am I, sitting crooked? All those things make a difference in regards to that awareness, but also the stress on the shoulder itself. So if you can start to change that behavior, and then get stronger and then sit up straighter and then move better, those are all things that are going to take stress off those structures so they don't wear away and end up in more of like a rotator cuff tear or that tendinitis or that osteoarthritis. So it's really about redistributing those forces over time.
So I think we're going to get into some of those exercises to help that,
Sure.
right? Or prevent it too.
Yeah.
So let's talk about, like you mentioned, that tightness and that
Sure.
mid-back too. Obviously we want to get more mobile in that
Sure.
area, right? To
Sure.
really open it up.
Yep.
So talk about what we would do for that.
Yeah. Do you mind being my...
I thought you never asked that. I was so excited for it.
All right, so one of the first ones we like to teach patients is just to get some more mobility through that upper back region. So why don't you put your phone in your pocket? That'd be great.
All right, I'm ready.
So what we'll have you do is let's have you put hands together. We'll call this sometimes we'll tell patients like praying hands position. And what Julie's gonna do here is she's gonna keep her hands together and she's going to rotate her upper body to one side, pause, hold for about 3 to 5 seconds, and then come back. And then she could either come this way again, or she can come this way, or repeat to the other side. It's really dealer's choice here, whichever you want to do in regards to going back and forth, or doing all one side and then doing the other. So what this is going to do here is this is going to start to mobilize, or that's good. It's going to mobilize and loosen up that area between the shoulder blades and also that thoracic spine. So the thoracic spine is that area between the shoulder blades. That's a very common sticking point for patients where they feel kind of stuck, like they can't move well through that area. So this is one of those, it's really good. I think one of the cues that we always give patients is as you're doing this, you want to make sure that you're not shrugging at the very end, just like Julie was doing there. So it's a very common fix that we have with patients is as you turn side to side, we don't want to be compensating and going to that shrug position. We want to make sure our shoulders are nice and relaxed as we're going side to side.
And for people at home that are watching, what are my hips doing? Like, are they trying to stay straight on the whole time so they're not turning?
Yep, so you could do this in 2 positions. You can do it in, like, sitting at your desk. So you can just do it throughout the day. That's perfect to do. You can do it in a seated position, or you can do it in a standing position, just like Julia's demonstrating. If you're in a standing position like Julia, toes forward, hips forward, and you really want that motion to be coming through more so that mid-back area. You don't want to be really letting the hips go with you. You want to be really keeping everything straight forward. Same thing goes for if you're sitting. You want to keep toes forward, knees forward, hips forward, and then that motion is coming from the upper back as opposed to letting everything turn.
And so you said 3 to 5 seconds, hold each time.
Yep.
How many times should they be doing it?
So I like to start patients with doing 10 to each side. Again, whether you're going back and forth or you're doing all one side and then the other, really whatever feels best for you. 10 repetitions either side. That's great to do, especially throughout your day. So if you're a desk worker and you find stiffness through that area, doing that 2 or 3 times throughout the day is going to be a great way to offset some of those bad habits with sitting, but also take some of that stress off of that mid-back area and also the shoulder as you're sitting there.
Great.
Another one, again, you can do this one in sitting or standing. So I want to be faced towards the camera here. So this next one, palms at your side like so. And this one, we're gonna focus on squeezing between the shoulder blades. Okay, so palms at the side, and you're gonna squeeze backwards, hold for about 5 seconds here, and then come on back. Another one, we're gonna focus on not shrugging here, so keeping the shoulders nice and relaxed here. That's a very common thing we see with patients. We don't wanna be going into that shrug position. We wanna keep the shoulders relaxed as we do it, because what we commonly find with patients is when we're in that slumped position, our shoulders are naturally in that shrug position. I couldn't tell you how many times I hear from patients like, oh God, I feel like my shoulders and ears are like so close to each other, or they feel like they just can't get their shoulders down. So this is a little bit of a re-education piece of trying to teach patients this is the better position for the shoulder blade and that mid-back, and this is a great postural builder of building that strength and stability in that upper back to offset some of this slouching that we do commonly.
Great.
This one I would do about 5-second holds. Again, 10 repetitions, 10, 15 repetitions is good. And then 2 or 3 times throughout the day is a great way to start, like we talked about before, that awareness, getting you in more of that habit of being in a better position more so throughout the day as opposed to constantly slouched or constantly in that hunched over position.
And then obviously I'm standing. Can they do this sitting?
You can do that one in sitting.
Okay.
You can do that in standing as well. Same thing applies there. You want to keep, if I was sitting in a chair, palms would still be out. You're still squeezing shoulder blades together, still avoiding that shrug. If it's easily more accessible to do it sitting, you can certainly do that. But it's always good to take a break from sitting and do it in a standing position. We'd always prefer standing over sitting because we do plenty of sitting throughout the day. So
yeah, especially if you're still working from home too, or maybe they're doing a more remote thing.
Sure.
You're not getting up to go to the water cooler or talk to your friend
absolutely.
or go to the bathroom.
I've had so many patients since COVID had happened, transitioning to home, so their work environment was way different. So they had a different work setup. So they're working from their kitchen table or their couch, and these are really tough positions to work on ergonomically. Because again, if you're sitting on your couch on your laptop, there's only one direction to go there. Yeah, down. Exactly. It's just that's how we end up, unfortunately. Another one I'd like to show you here is, so you're going to hold those handles for me. Are we still good here?
Yep, they can see you.
Okay, so what we're going to do here is we're going to do actually a row position. Okay. I won't let go, I promise.
Please don't.
I'll never let go, Jack. So what we're going to do here is we're actually going to do a row, but we're going to do a single arm at one time. So there's going to be a little bit of rotation in your upper back. So let's do your right side first. So what you're going to do is you're going to pull backwards, and you're going to also rotate your upper back as you go here.
What are my feet doing? Are they like
your feet are good right where they are. If you want a little bit more of an athletic position, you can stagger your feet, where you put that left foot would come forward.
Okay.
And you'd be in a little more of a stagger position, and we're going to be pulling with that right side. So think what we were talking about before with that, we call that military posture, where you're squeezing the shoulder blades together. You're going to keep that same idea in mind here as you're squeezing that shoulder blade back and also rotating that chest. So we're almost combining those first 2 exercises that we did. However, this time we're adding a little bit of resistance as well. So this is a good progression for patients if you have these available to you. This is a great way to work. If you don't have a resistance band at home, a great way to use this as well. If you don't have a resistance band, you can use small dumbbells as well. You'd be in more of like a bent over position. We'd be leaning on something and doing like, they classify as like a bent over row instead. It's the same concept. And if you don't have weights at home, you can just start with like soup cans, water bottles, anything that has a little bit of weight to it if you don't have resistance bands. Why don't you do the other side too?
You don't want me to get a...
Gotta be even.
And how many times? And what are my hips doing? Are they staying straight on?
Yep, so we want the hips to stay pretty forward because we want the motion to come through that upper back. Not only is Julia squeezing that shoulder blade in the upper back, but she's also getting some good rotation through that upper back. So again, these are the principles that we always teach for patients, is being able to rotate and being mobile through the upper back, but also being stable through the upper back to make us more resilient throughout the day, to kind of fight against the hours and hours that we sit at the desk. So another one that we can do with the resistance bands is we're going to be in more so just like our military posture position. So let's have you straighten your elbows out a little bit more, and then palms towards me, actually. There you go, good. So what you're going to do here, you're going to basically do that military posture exercise, but now with added resistance. Okay, so again, shoulders down, squeezing backwards, good. This one is a little bit more, some patients might classify this as like a fly position as well. But again, this is more of a progression on top of that military posture exercise that we first showed.
You want to angle a little bit so
Sure.
then they can see it from this way
Yep,
too?
absolutely. Again, this one, you probably wouldn't hold for as long as we were doing, but starting more so squeezing shoulder blades together, hold for maybe just a couple seconds just to pause, and then starting with sets of 10 is always a good thing to do there, and then building up as you go, whether it's adding sets or adding more resistance as you go.
Right.
Okay. That's if we also have one other one as well. So this one, let's turn to the side. So, or actually, you can face this way. So we're gonna drop one handle here. I'll take this one. Good. And we'll put it in your left hand. Good.
Okay.
Straighten your elbow out.
On the side.
Actually, go back to the same position there. Sorry. So we have two different variations of this exercise that we can do, again, with the resistance bands. So this is really more working like the rotation of the rotator cuff. So you're going to be pulling the band in front of you, like so. Good. And then return to the start position. So this will be working her left shoulder, working more into the internal rotation. Now that's kind of getting into the weeds a little bit, but our rotator cuff is pretty dynamic. It has a lot of motions that it supports, so we need to be able to move it in different positions. So this would be classified as internal rotation because she's pulling inwards. So you should feel work around the shoulder blade with this one. So again, this one, you're not really going to hold this one too much, but you're going to be pausing at the very end, just slightly, like 1 or 2 seconds, just to feel that work, and then you're coming right back off it. Again, starting with 10 reps is fine, and then progressing into more sets, and then adding more resistance.
And my elbows like tucked in at
Yeah,
my waist.
exactly. You don't want
out.
to. Yep, exactly.
Okay.
The next one, so just for logistically, we're actually going to switch to your right hand.
Okay.
Good. So this one is actually going to be working her right rotator cuff, but more so the external rotator. She's a student, so she already knows what to do. So again, that rotator cuff is very dynamic, has a lot of motion. So this is just one of the other motions that it does. It's working on external rotation. So she's going to feel it in a little bit different spot in the shoulder blade.
Yeah.
But all these, just like Dr. Binkley was talking about, all these muscles originate from the shoulder blade. So a lot of times you're going to feel a lot of work, at the shoulder blade, which can be confusing for some patients because they're like, well, I thought it was more like the ball and socket joint, but you're feeling a lot of work around the shoulder blade. That's really the basis or the foundation of a lot of these things. We want to have that good solid foundation that we can move around as opposed to just the ball and socket joint itself.
Great. And
Okay.
how many of these?
Same thing, again, that pause at the end just to feel that work, and then starting with 10 reps and then building up from there.
Awesome.
So it's a pretty good, like, kind of, I'll take this, beginner program, if you will, of getting some good work around the shoulder blade, but also getting some rotator cuff activation as well. Because again, that's both pieces of the puzzle. You have that ball and socket joint, we have the shoulder blade, and we also have that mid back as well. Getting all those areas moving.
Great. So let's talk about how do you recommend people progress too?
Yeah.
I think you elaborated.
Yeah, we
little
touched on
bit.
that a little bit. So when you're thinking about progressions, we get this a lot of times. Patients will go to the gym and they'll use the machines, right? So it's better than doing nothing. However, from a stability standpoint, it's always better to use free weights as opposed to machines, just because a machine is more like a one size fits all type thing. Whether it's someone can be 5 foot tall or 6 foot tall and they're built differently, but they're using the same machine. Whereas opposed if you use a free weight, you can kind of dictate where that free weight goes. So working more so like from the machine to free weight, and then always being aware of like your limitations. Some patients will come in and say, I can't reach up overhead, but you look at their gym program and they're doing like shoulder press overhead. So a progression for that patient may be like working everything from shoulder height below. And then once you feel good, then we can progress to working to overhead activities. But that old, if it hurts, don't do it, sometimes is too obvious for patients. And we want to make sure we're doing things that feel good first and foremost. And then when you're ready, you can progress positioning, like going overhead, and then progressing to free weights, or then also progressing the weight itself.
Well, I think also too that like a lot of the machines, maybe you're sitting down too, but a lot of the stuff that maybe they're doing at home, they're standing up, kind of like you talked about.
Yeah, we touched on that earlier. Like if we had a choice between sitting or standing, some patients sit all week and then they drive to the gym sitting and then they go sit down at the gym to do more exercise. So just getting you up on your feet is going to be a much more active position, much more functional. So it's we would always choose to be in a more functional position in standing as opposed to sitting, because again, if you struggle with your sitting posture and you go to the gym and sit down to do maybe a machine that involves shoulder press, if you're in a bad position sitting and you go to do that exercise in sitting, you're increasing your risk for putting more pressure on those structures of the shoulder. Whereas if we get you into standing, more than likely you're going to have a better posture or a better position to even start working out in.
Great. So we have a couple questions
Okay.
from everybody watching. So the first one is pain in the front of the shoulder a rotator cuff injury or something else?
It depends. So a lot of times, that's my favorite answer. You can ask my patients. So a lot of times pain in the front of the shoulder can be indicative of more so biceps tendon involvement or like a biceps tendinitis. However, it's like a loaded answer, a loaded question too, because a lot of times if we have weakness in our rotator cuff, we don't have good control of that ball and socket, and the ball and socket can actually slide forward into the back of the bicep tendon and actually cause that irritation kind of secondarily. So again, that's what we talked about before, where it's like painful tissue versus dysfunctional tissue. Yes, your front of the shoulder may hurt, and it actually may be your bicep tendon that is irritated, but what is the cause of that irritation? It may be just simply that lack of rotator cuff strength that's letting that ball slide forward, running into the back of the bicep tendon. So
still needing to do some of those exercises.
Exactly. So yes, so that's really where we start for a lot of our patients, is controlling more so that ball and socket joint as opposed to letting it slide forward, irritating the bicep tendon. So I guess I danced around that question, said yes, maybe, and that could be the answer why. So
sounds like they may need your help. So
good at avoiding questions.
Yeah. I have a herniated disc at level C6, C7. How can I tell if my shoulder pain is really coming from that or something else like an impingement or rotator cuff tear?
So we see that a lot of times where someone will come in with a diagnosis of either neck pain, and whether it's we're always going through our evaluations with patients and seeing what is the root cause. Is it truly the neck that's referring to the shoulder? Is it a shoulder issue that is looking like neck pain? So going through a thorough evaluation with one of our therapists is the first place to start there. It's a very tough thing to kind of diagnose without seeing someone move. So first things first would always be to just get evaluated first, just before you start jumping into a program, just so you aren't, working against yourself and, addressing something that actually may not be an issue, might be more so a neck issue, or so as a vice versa, a shoulder issue.
Great.
So.
Can you talk about reaching backwards, like trying to scratch your back? I can only reach about to my belt level, then I feel pain in my upper outside arm.
Gotcha. I couldn't tell you how many patients struggle with that reaching behind the back. So, patients, whether they're trying to tuck their shirt in, feed their belt through, women unhooking their bra, that's a common thing we see that just struggle with. So that's a very advanced move of the shoulder. So you need a lot of, number one, motion of the ball and socket joint. You also need a lot of good motion of the shoulder blade and a lot of good motion of the thoracic spine in order for that to happen. So the problem is, if we don't have good motion on 2 out of those 3 things, all of the work is going to be done by the ball and socket joint, which will result in a lot of that pinching sensation in the arm as they're reaching behind, which is a classic case of, again, things are not moving, which are putting more stress on the ball and socket joint that result in more of that pain in the shoulder as you're trying to do a reach behind the back. So that's where we would go more of our functional approach of treating everything that gets you moving better altogether, as opposed to just, looking at the shoulder itself.
Great. We had one more of what's the best way to determine how much weight I should be lifting?
So we're always looking at kind of form. So when you're doing whatever exercise it may be, so like we talked about how to progress some exercises before, we always look at form. We want to be able to complete an exercise with good form and the full set without the weight changing your form. So if you're doing something, I mean, everyone has probably seen it at the gym where you see someone doing, too much weight. That's a recipe for disaster. So you want to be able to do your full set at that weight, and if you can get through that whole set with that resistance, whether it's a dumbbell or actually using like resistance bands, if you can get through that whole set with no discomfort, then it might be time to progress, whether it's, again, like we talked about before, adding another set or adding more resistance, whether it's a dumbbell or a heavier resistance band.
Yeah, my thought always with that too is you have your whole life to lift weights
Yeah.
too if you want it. So
You gotta
start
get after
slow,
it.
and then if you realize you need to go up, then you can go up after you did your
Sure.
last set.
Sure. So wise.
Yeah.
So wise, Julia.
That's my little tidbit for the night. I didn't contribute much. I just asked the questions, but that'll be all I say. All right, awesome. Well, I think that was all the questions we
Great.
had. So thank you so much, Matt, for joining with
Yeah,
us.
absolutely.
Oh, wait, actually, I think there might be one more.
Okay.
So I'm waiting for it to come through. But basically, I wanted to let them know while we're waiting for this last question that to check your email tomorrow, because we'll be including additional information and review some of the exercises that Matt talked about in case they forgot them or maybe want another review. So the one was, can someone with bone-on-bone arthritis do these exercises?
So it depends. See, I told you to come out again. This is one of those things that we would obviously like to see someone do them first and how you're moving before we even jump into these exercises. A lot of times with patients, we like to see how they move first. And what I mean by that is, like, do you have their prerequisite, mobility and strength to do these exercises? You may be someone that needs to start with our very basic exercises, like just the prayer hands position, turning side to side, and then that military posture. So nothing with resistance and nothing with reaching up overhead. It all comes back to, again, our foundation of mid-back, shoulder blade, and that ball and socket. So if you have that bone on bone in the shoulder, it's probably because those other areas aren't doing enough, and all the stresses ended up on that ball and socket joint. So we might need to focus more so on that shoulder blade and that mid-back first before we even start to add in those resistance exercises. So my best guess without seeing this person would be probably not to do those yet, and focus on the other more basic ones of getting moving first. And then after they get evaluated by one of our physical therapists and they get the green light, then they can start doing those things. And then it's honestly just better for that person as well, because if you just jump into those with without really knowing like what is my specific problem,
Yeah.
you may just start to irritate things more. And I don't want another angry email from patients saying like, I can't believe you told me to do that exercise, but always
Never get those.
No, never.
You're great, Matt.
I think that's my wife. No, I'm just
It's
kidding.
your wife, yeah. She's watching too.
Oh,
and She's
okay.
going to send you
All right.
another one.
I should go home then.
All right. Well, thank you, Matt, so much. Thank you all for watching. We hope you found this informative. As always, if you guys have any questions, please feel free to reach out. Enjoy your evening. Enjoy the sunshine starting to come out and slowly getting out of
Fingers
that winter.
crossed.
And we'll see you guys soon.